it was an honor to share the podium with my colleagues at the EHA Satellite Symposium on CAR-T and lymphoma. And, I had the pleasure to talk about mantle cell lymphoma. We know that in mantle cell lymphoma, there's been a paradigm shift from chemotherapy to targeted agents and immunotherapies recently with incorporation certainly of BTK inhibitors, CAR T-cell therapy, and prior to that, immunomodulatory agents, as well as now emerging data with bispecific antibodies. Clearly, BTK inhibitors have made a significant impact in mantle cell lymphoma, but there is an unmet need post-BTKI therapy, and the overall survival for patients who fail BTKI therapy is not good. This is the space where there are new treatments which have evolved. Beyond covalent BTK inhibitor, drugs like pirtobrutinib have made a place in mantle cell lymphoma, but we still need better treatments, and so that's where CAR T-cell therapy came in, and the first CAR T-cell treatment which was approved in mantle cell was brexucabtagene autoleucel, also called brexu-cel, and so this is from the ZUMA-2 study, which looked at patients with relapsed refractory mantle cell after 1 to 5 prior lines of therapy, and here in this group of patients, you did see patients who had high complete response rates, over 90%, and also high overall response rates and complete response rates. I believe about 2/3 of patients had a complete response. And again, similar to most CAR T studies, we found that patients who achieved a complete response had more durable responses compared to those who had a partial response. So, these were highly refractory patients, high-risk patients, and we were able to see durable responses in this group. Longer follow-up is necessary. There is, certainly risk of CRS and neurotoxicity with brexu-cel, which is higher because, with this particular drug, and then there have been strategies for early use of tocilizumab and steroids, which have been able to show that by doing these strategies, there can be a slight reduction in CRS and ICANS with brexu-cel. And then there have been real-world studies also which have replicated some of this data, showing again excellent response rates, again around 90%, and good progression-free survival, considering how refractory these patients have been with relapsed refractory mantle cell lymphoma. Following brexu-cel, there have been new data from Lisocabtagene maraleucel, also called liso-cel, which has already been approved in other diseases like relapsed refractory large cell lymphoma, and now in follicular lymphoma, CLL, as well as now mantle cell. So that was data from the TRANSCEND study in relapsed refractory mantle cell lymphoma, which again included a large number of high-risk patients. One thing to note was in this study compared to the ZUMA-2 study, they did not restrict up to 5 prior lines of therapy. In fact, about a quarter of patients were more than 5 lines of therapy, which is quite remarkable. So very high risk, heavily pretreated patients again included on this study. And what we saw is a high overall response rate of 83% and a CR rate of 72%. So again, really good data with this study. Patients who achieved a CR had more durable responses, and the duration of response was nearly 16 months. As well as the progression-free survival about the same. So, again, very, very effective treatment option for mantle cell lymphoma using liso-cel. Now, I'd mentioned that this study included patients who had greater than 5 prior lines of therapy, and even in this group, we saw, effective responses. So certainly heavily pretreated patients can also benefit from CAR T-cell therapy. Importantly, with liso-cel, we saw numerically, again, this is not a head-to-head comparison between the two products, but we did see CRS rate and neurotoxicity rate, which seemed to be lower, consistent with prior studies with liso-cel, and that is probably related to the 4-1BB, which liso-cel uses compared to CD28 used in other products. So a relatively safe option using liso-cel and still achieving really very effective responses. Now, while this is great, there are certainly many barriers to receiving CAR T-cell therapy, and these include patient-related factors, disease biology. Some patients have very aggressive disease and may not be able to wait while CAR T cells are being manufactured, and also the time it takes often to get patients access to CAR T cell therapy, including insurance clearance and things like that. Costs can also be an issue, and availability of a CAR T center in the proximity and caregiver support can also be issues. So there are many challenges which still remain, but nevertheless, liso-cel has now been approved in mantle cell lymphoma in the relapsed refractory setting. Brexu-cel has already been approved in the past. So these are all good options, and I think newer treatments, including bispecific antibodies, are also showing really good responses. So I think the future is bright for patients with mantle cell lymphoma in the relapsed refractory setting, and hopefully we'll continue to see more progress as time comes along. Thank you.